Welcome everyone to the Central Line Bundlecare, an evidence-based initiative created by Carly Chalison, Joseph Delidi, Jamie Fogelsonger, Kathleen Macabitas, Danae Mack, and James Snyder. A bundle is a structured way of improving the processes of care and patient outcomes. It is normally a small set of evidence-based practices that, when performed collectively, have been proven to improve patient outcomes. By implementing bundle care in central line insertion or maintenance, the aim is to decrease central line associated bloodstream infection, otherwise known as CLABSI, through preventative measures. CLABSI is defined as a primary laboratory confirmed bacteremia or fungemia, excluding skin flora, in a patient with a central line at the time of or within 48 hours prior to the onset of symptoms, and the infection is not related to an infection from another site. Research evidence supports that implementation of a central line post-insertion maintenance care bundle is associated with a reduction in CLABSI. The Institute for Healthcare Improvement and other national and scientific organizations promote care bundles as part of its effort to improve patient safety. The Iowa model was used in this study as a guide for evidence-based practice to promote quality care. In future slides, we will discuss some problem-focused triggers that suggest a need to implement bundle care in central line maintenance. Our team was able to acquire some relevant research and related literature. The literature was critiqued and synthesized by our group in providing sufficient research support. We will discuss our outcomes, data, our evidence-based practice guidelines, and our proposed change. Some triggers to action in implementing central line catheter bundle care maintenance include an increase in hospital stay. Patients are remaining in the hospital longer than expected due to complications associated with central line infections. There is a current increase in exposure to antibiotics. Patients are constantly being treated with antibiotics due to infections relating to their central line catheters. There's also an increase in morbidity and mortality. Approximately 31,000 deaths annually are reported due to central line catheter associated bloodstream infections. Unfortunately, central line insertion bundle adherence alone does not ensure a patient will remain free of CLABSI. There may be a need for additional preventative measures in the bundle to improve patient care outcomes. There are also some financial triggers related to central line associated bloodstream infections, and these include excess in costs. $2.3 billion in the US is spent annually in correcting infections associated with central line catheters. As mentioned before, there's a current increased length of stay for patients, which in turn lead to an increase in expense by the hospital. Currently, Medicare and Medicaid services do not reimburse for central line catheter infections, forcing the hospital to take responsibility for those costs. These complications can be prevented by a systematic approach to central line maintenance care. It should be noted that meticulous sterile insertion technique is of importance, along with post-insertion care. Failure to implement proper bundle care, CLABSI represents a serious patient safety issue. Using evidence-based practice in this study, we would like to answer the PICO question. In patients in the ICU with a central line, what is the effect of Bundlecare on reducing central line associated bloodstream infections compared to not implementing Bundlecare? Our intervention in this study is to implement a Bundlecare checklist in central line catheter maintenance in ICU patients to reduce the incidence of CLABSI. The Bundlecare checklist includes a few of the following prevention measures. The Institute for Healthcare Improvement recommends the following maintenance criteria for prevention of CLABSI: hand hygiene, chlorhexidine for skin disinfection, a daily review of the lines necessary for patient treatment, and prompt removals of unnecessary lines that still remain in the patient, and maximizing barrier precautions. The comparison intervention in our study includes comparing the usual care being performed on central line catheters on patients in the ICU. The desired nurse-centered outcomes includes an increase in competency for aseptic technique, an improvement in documentation by implementing Bundlecare checklists, and an improvement of standard of care. Some patient-related outcomes include an improvement in patient satisfaction, a decrease in the incidence of CLABSI, and a reduction in overall hospital-acquired infections. Additional outcomes that will be measured include cost avoidance in the hospital, a decrease in mortality rate in the hospital, and a decreased length of stay in the hospital for patients. The purpose of this evidence-based practice project is to implement a practice to improve central line maintenance in ICU patients and decrease the incidence of CLABSI. An evaluation of central line maintenance Bundlecare will be performed in one ICU at Scripps La Jolla in San Diego. Data will be collected at 4 different quarters throughout the year. 2 pre-interventions will be collected during the first half of the year, and 2 post-intervention data will be collected during the second half of the year.
The databases used for our literature search were CINAHL, PubMed, and Google Scholar. The keywords or search terms that we used were central line associated bloodstream infection, CLABSI, ICU, bundle, and meta-analysis. All articles that were reviewed were published within the last 10 years. When using the abbreviation CLABSI as a search term, we received a large amount of articles in our search results. We received almost 300 article results in the current Nursing and Allied Health literature database when searching for CLABSI. Also, we received almost 400 results in PubMed using the same search term. Our most effective search term combination was CLABSI and ICU and bundle. For that combination, we received 13 results in CINAHL and 17 results in PubMed. When we searched to find meta-analysis article results, we received 3 results for both CINAHL and PubMed. From our literature search results, we chose 7 articles for analysis. Of the 7 articles chosen for analysis, these articles consisted of systematic reviews, meta-analysis, randomized control trial, quasi-experimental design, and cross-sectional studies. The inclusion and exclusion criteria used to pick these articles out were peer-reviewed materials written in English. We wanted systematic reviews, research articles, and evidence-based CLABSI prevention bundle checklists to be included in those articles. We also were looking for target population of ICU patients of all ages, of any race, ethnic background, or gender. Our criteria also included searching for subject matter that included the care elements of hand hygiene, chlorhexidine, skin disinfection, daily site review, and barrier use as part of the maintenance bundles mentioned in those research articles. We also were looking for patient outcomes to be mentioned in those articles, whether there was an infection acquired or not. For our inclusion and exclusion criteria for our literature search, we also wanted the research study design in the article to properly address our research question. We were looking at the sample size and sampling techniques to make sure those were appropriate for our study design. We wanted the analytic techniques to be appropriate to measure the variables we were looking at, particularly the dependent variable of whether CLABSI was acquired or not after the Bundlecare intervention. We were looking at the research findings to be clearly addressed and written in the articles, and for systematic reviews, we wanted them to be clearly performed and reported. As mentioned, we were looking for a CLABSI prevention maintenance bundle checklist to be included in the research articles. We wanted these checklists to be well referenced. Also, we wanted the care elements included in these bundles to be evidence-based practices. To grade our evidence, we chose the Johns Hopkins Nursing Evidence-Based Practice Appraisal Tool. Evidence levels are divided into level 1, 2, and 3, and quality guidelines include high quality, good quality, and low quality, or major flaws. Each article was analyzed for the level of evidence and quality of the article. When grading our evidence, we found that 3 out of 7 of our articles were categorized as level 1 and high quality evidence using the Johns Hopkins Nursing Evidence-Based Practice Appraisal Tool. 2 of these 3 articles were systematic reviews that both included meta-analysis. The systematic reviews were on randomized controlled trials, making these level 1 evidence articles. Also, the results for these articles were consistent and generalizable, and the reviews were comprehensive, and the recommendations were clear, making these high quality articles as well. The third article that was graded as level 1 evidence was a randomized controlled trial that used a cluster randomized method. It included 45 ICUs from 35 hospitals across 12 states. The intervention group was 23 and the control group was 22. Random number generation was used to assign each hospital a number, and the researchers blindly sorted the numbers into 2 groups. This type of control measure would make this a high quality evidence article. One of our bundle care elements is hand hygiene. Hand hygiene is an evidence-based intervention used to prevent the spread of infections in hospital settings. Another care element for our bundle is chlorhexidine skin disinfection. This is also an evidence-based practice. When using ChloraPrep, a back and forth friction motion for at least 30 seconds and letting the solution completely dry are the most effective ways of reducing a patient's risk for acquiring an infection. Nursing assessment is a key element to preventing infection. We wanted to include for our bundle care, with the goal of preventing CLABSI, that the nurse should perform a daily review of the line to assess for signs of infection and to also assess for necessary removal of the line. PPE is a care element part of our bundle. We decided on maximal barrier precautions. Specifically, we have seen this in other studies conducted on CLABSI prevention in other facilities as being very effective for preventing this infection. Our proposed practice change is to take these evidence-based practices that have been shown to prevent central line acquired bloodstream infections and use them in combination as a bundle for the purposes of potentiating all these elements' ability to significantly lower a patient's risk for developing CLABSI. To train nurses on this new practice change, there is a 1-hour in-service training led by a nurse educator or charge nurse that will be on the bundle care elements and how they are to be used in combination. Also, computer chart training for documenting the bundle care measures implemented and to show that they were implemented together, as well as documentation of the presence of infection as part of the nurse's assessment charting. Here's an example of an intervention checklist or a bundle care checklist for CLABSI. A bundle checklist should be made and tailored to the facility.
Our evaluation design is a quasi-experimental time series. In this type of series design, participants or groups act as their own controls, making a group that does not receive the intervention unnecessary. With the time series design, we are looking at the differences and not correlations. Our measurement tool is the central line bundle compliance. So we're basically measuring the compliance with the central line bundle care, not just as parts of the bundle. So on a given day, we select all patients with central lines and assess them for the compliance with the central bundle. If even one part of the bundle is missing, the case is not in compliance. For example, if there are 7 patients with central lines and 6 have all 5 bundle elements completed, then 6 out of 7 are in compliance with the central line bundle care. This would correlate to 86%. Our setting is in the ICU at Scripps La Jolla, San Diego. There's roughly 20 to 30 occupied beds. We're looking at both male and female patients of adult ICU patients receiving central line care. The ages are roughly 18 through 56. And we approximately have 10 to 15 patients a day receiving central line. Our sample size, and plan are as follows. The sample is the admitted patients to the ICU receiving central lines for up to 12 months. The first 6 months is without bundle care. The second 6 months is with bundle care. The nurses will be educated on how to properly implement the bundle care checklist. Our estimated sample size is 1,820 to 2,730 patients for 6 months. And we're using the one-way F-test. Data collection will proceed as pre-intervention of 3 months, pre-intervention again at 6 months, post-intervention in 9 months, and again at 12 months. Our data analysis example is a one-way analysis of variance 4x4 ANOVA with repeated measures over time. Since we are evaluating by 1 unit over time with different participants, we chose to use a one-way analysis of variance, an F-test statistic. A few possible biases include nurses reporting that they implemented bundle care when they in fact did not implement the bundle care checklist, or nurses cutting corners by stating that they implemented one of the bundle care items, such as hand washing, and in fact they didn't do proper hand washing. Maybe they didn't choose to use soap during their hand washing, or they just quickly rinsed their hands. Another bias is the nurse differing perception on how to properly implement the bundle care and not sticking to how they were educated on it. There are few ethical considerations to consider since collection of data will exclude patient identifiers. All documents will be kept locked up and limited access to only researchers. We're going to request a waiver of documentation for patients participating in the study. This is because our bundle maintenance is of no more than minimal risk, and the procedures would not require written consent when performed outside of the research setting.